All right. Thank you very much for having me on this panel, the Sudan's program. This is my second time in this space. I'm very grateful for the opportunity. I saw some people from YPR. I am a product of the YPR space. And so it was really good to see a Jaylee earlier on today. My name is Ayak Chol Deng Alak. My background is medicine and surgery from Ahfad University, Sudan, and my master's from the Methodist University in Nairobi, Kenya, in public health. I also dabbled in media as a presenter for radio and television, and I am also working in peace and security, and so the intersectoral aspects of health. I'm very grateful to be in this space. Okay. So my presentation specifically focuses on the misconceptions and the role of media in combating COVID-19. So I will strictly speak on myths, misconceptions, and the role of media, and my colleagues will then further the conversation into the other aspects of COVID-19 combat in South Sudan. All right, so the numbers that we have so far, as of yesterday, 18,368 confirmed COVID cases in South Sudan, 138 number of deaths as of January. We still don't have updates on the current number of deaths, and number of vaccine doses, and not people vaccinated, just the doses themselves. They're slightly over 2.3 million. I wanted to start with this graph. Not only does it give us the map of South Sudan, but it also gives us the neighboring countries. This is a population flow. And this was around the time that we first had our first COVID case in South Sudan. As you can see, we are neighbored by various countries, and all countries had already started registering cases around the time prior to South Sudan registering its cases. And this could be for numerous reasons, not because we have the best health system, but at the time, I don't think there was so much information around COVID-19. Countries were just now starting to set up measures on how to monitor and deal with the disease itself. And so this is very important, this population chart, to show the flow of movement of people in the different locations across South Sudan. For those that are familiar with the map, you see this heavy movement along the borders, especially the DRC Congo and the Ugandan border. There's little movement around the Kenyan border, but there's also movement around the Sudan border as well, and minimal movement around the Ethiopian border, mostly because of shared communities, but also because of these other factors. So communal conflict, as of 2019, around the first cases of COVID-19 appeared, and we saw within South Sudan a surge in communal conflict around the time. This was around the time where there was the extension of the peace process at that time. The revitalized peace agreement the time assigned to it was just lapsing, and the government had then decided to go ahead and extend the peace agreement, the period for the peace implementation. Around that time, there was extensive communal fighting around the Jonglei area, around the central Equatoria area, all the way to the border, to eastern Equatoria, around the Ugandan border, Madiland, and then also towards 2022 and 2023, we saw more communal fighting around Abyei area as well. Another factor that is shared between the Sudans is the flood situation. We have seen just a tremendous levels of floods juxtaposed with also some dryness in some areas. And these floods were really unexpected. The communities were not prepared for it. And as a result, we saw a lot of displacement. We saw a lot of communicable diseases. displacement as well as a result of the communal conflict with local communities seeking places for refuge. And then we also saw surge of conflict between herder communities and farming communities, which also resulted in IDP situations and refugee situations. And then again, like I said, the famine and also interruption of food distribution. In the wake of COVID-19, what we saw was INGOs and local NGOs, but particularly INGOs that bears the burden of humanitarian responses in South Sudan, take some sort of a backseat. They evacuated most of their staff as they try to find ways to deal with COVID-19 and the humanitarian situation and the conflict. And so there was a gap in humanitarian aid delivery as well as health service delivery at that time. So all these factors together just exacerbated the spread of COVID and also contributed to the underreporting of the COVID cases. So the misconceptions, very interesting actually. So most people on the African continent believed that being in the sunny climate somehow protects you against COVID-19. COVID does not spread in the hot climates. And these are also similar misconceptions that are shared between Sudan and South Sudan and other parts of the continent. During the COVID-19, it was like a booze fest, especially for the upper middle class. It was especially when there was a short term of lockdown. It was when friends gathered together and had their drinks and just said, hey, alcohol is a sanitizer. And so there was a spike in alcohol consumption, both among the urban, but also in the lower classes. They were drinking locally brewed alcohol. And then there was the misconception that this is a white man's disease. We Black people are immune from it. You know, there was also these assumptions that this is strictly a Chinese disease. And so there were a lot of misconceptions around that. There was also the rumor that COVID it spread through mosquito bites, and that kind of raised people's fears around COVID-19 as well. There was also a lot of faith-based misconceptions, and this is extremely important because we come from populations that, even though are not so religious, they are quite spiritual. And so we saw a lot of churches providing anointing oils and stories of recovery and testimonials, mosques providing scriptures to quote, and herbal and traditional medicine men and women really made a killing. They really made a lot of money during that time because they, presented themselves as having the solution to COVID-19. There was a rumor that started in Sudan and then it reached South Sudan. Some young kid somewhere had a vision about tea being the solve-it solution. And so people called from everywhere to remind us to take our tea diligently. So these were some of the misconceptions around that time. There were some of the herbs that you could either smoke them and make some sort of incense out of, or you could boil. So there were so many non-proven alternative remedies that were circulating, and people somehow gravitated towards them as familiar alternatives. There are also some vaccine-related misconceptions, and these were particularly difficult to deal with. There were a lot of theories. Vaccine affects the DNA. These vaccines were produced very quickly and they're not effective. This particular one, the fact that the assumption that it affects fertility and it causes impotence in men, and it causes primary and secondary infertility in women, was also another serious misconception and misinformation that was being generated even among educated people. Other misconceptions that were not necessarily vaccine related were that if you're young and healthy, you don't need the vaccine. The vaccine does nothing to you. If you got the disease once, you can't get it again. And if you don't have a fever, you definitely don't have the disease. And so these are also some of the misconceptions that somehow contributed to the spread of COVID-19 in South Sudan, and some of the messaging that that also constituted targeted messaging for the combat of COVID on the media. So how South Sudan dealt with it at different levels. At the presidency, there was an appointment of a COVID task force that is headed by one of the vice presidents. And this task force also worked together with other health professionals and media experts and developed a media strategy with a centralized unit for communication. And so there was always information that came from the media unit of the COVID task force. All other information was considered not trustworthy. There was also the mainstreaming of medical and other health unions. So the medical fraternity and other health institutions and associations thought it was the right time as well to get their structures in order, to get their hierarchy in order, to get their internal comms in order, to just get better organized to deal with this. We also saw a lot of collaboration between mainstream and non-mainstream organized institutions. So you have institutions like the church were involved, the schools were involved, universities, but then you also saw institutions like the Border Riders. And the Border Riders, for those who are not familiar, these are the motorbikers who are a source of public transport in South Sudan. So they do have their informal associations, and those two were involved in this campaign. Additionally, there were hotlines for critical cases. And then, of course, there was continued update on national preparedness just to alleviate people's anxiety, continued messaging on various forms of media platforms, just to make people calm and reassure them on the status of government and, the health system handling the disease. Now, some of these strategies are megaphones. There was use of megaphones. We call it locally Sultan Jambo in Arabic Juba. And Sultan Jambo would just be moving around the streets of Juba, somebody speaking in very simplified Arabic or simplified local language, depending on where. So if it was somewhere in Awil, they would probably speak in simple Arabic and the Dinka language. If it was somewhere in Yambio, they would speak in simple Arabic and the Zande language, and so on and so forth. There was also under tree sessions that was organized with community leaders and health workers just to encourage ownership of the combat. There was radio programming and television programming on daily basis, vox pops from people on the streets, on being asked questions, short audio messages that went all over in local languages and in simple Arabic. There was also daily newspaper updates that was issued by the COVID task force. And then telecoms companies also organized quizzes and trivia. And if you got the question right together with radio stations, then you would get airtime on your phone. And that was also another good incentive. There's also the recording on the phone itself. So for up to this date, if you make a phone call to a South Sudanese number, the first thing you hear is a messaging on COVID-19, what you should and what you shouldn't do. And then also there was a lot of work with the visual art, the art fraternity, visual artists and musicians. And there was also some work with digital influencers for social media, for Facebook and for Twitter. And I was lucky enough to be one of those digital influencers. All right, so as you can see, these are just a few photos. The gentleman here, Sultan Jambo, and this is the gentleman on the car is from the church, and they also used preaching time as also time to speak a bit about COVID-19 and a session with local leaders at village level under the tree. So what were the challenges besides everything that I have mentioned? Other challenges, which is also something that we share in common with Sudan, is the social setup. You are expected to show up at a funeral. You are expected to show up at a wedding. It's church. You have to be there. And so just our social and our cultural context made it challenging to implement some of these SOPs like social distancing and that. Also, low literacy levels made it a bit difficult as well for the dissemination of literary consumable content. Poverty is another thing. 98% of South Sudanese live on a daily income basis. And so if you tell people not to do this, if the standard operating procedures, to combat COVID somehow interferes with how they earn their living, then they're most likely not to listen to it. The rural-urban migration in the wake of the violence, but also in the wake of just the poverty itself, the economy was doing really, really bad. The flooding, the displacement, it was just a difficult time. And so it made both government and local populations, honestly, not necessarily prioritize the combat against COVID as it should have been. The health system was also overwhelmed. There was, because of the floods, all these communicable diseases and the cholera. There was the threat of Ebola at some point. And then just the usual added all onto that, just made it a little bit more difficult. And then there was the digital divide as well. Even among health practitioners, the high cost of tariff, the high cost of internet in South Sudan, it's crazy expensive. And so it makes it very difficult just even for people within the medical fraternity to keep updated and to keep their communication just at par with how the information is flowing. And so information flow was a bit challenged there. So the lessons learned was working with the local communities. Of course, that encourages ownership. You come, you do your sensitization, and you leave the space. And so it was really around how to have communities own these initiatives to combat COVID-19, how they could own these messages and continue them in the absence of an enforcing agent. And also context and target specific messaging. It was in the local languages. It was definitely in Bari and in Dinka and in all these other languages. It was very simple. And if it was on Twitter, then the language that was used for the people that consumed social media on Twitter was different. If it was Sultan Jambo, then it was very simple, broken down Arabic that, the majority of South Sudanese can understand. So the messaging was specific to the media outlet that was being used. Additionally, the role of art cannot be overemphasized. There was a lot of radio drama, there's visuals, songs, contracts with a lot of local musicians, just to ensure that the non-literate populations as well understood the messaging. Also, the medical fraternity also took it upon themselves to be on different social media live streamed events to give sensitization sessions on COVID-19. And that was another magnificent use of Facebook particularly. Additionally, the continued transparency, of course, and then also contextualized interventions. And this is something that Ajali mentioned in his presentation, really decolonizing the messaging and decolonizing how we react or how we respond to health crises. For instance, if you're at the cattle camp, soap is a luxury. And so the messaging would be, wash your hands with ash and water, for instance. And so it was messaging like that also that allowed for the consumption of the message. All right, the recommendations, of course, the context-specific intervention is something that has to be carried forward. Allocating funds for local research and for local researchers. There is this other element of the the humanitarian world, INGOs really need to bring in more local actors. During crisis situations, INGOs, which bear the brunt of humanitarian and other crisis responses in South Sudan, are evacuated because of the threat level. And so you find all the, the foreign community leaving, and they would drop everything and leave. And so if it is food distribution, it stopped. If it's health interventions, it stopped. And in this context, even COVID interventions, now people had to find ways on how to reach these areas that were basically run by INGOs. And so, even as we deal with pushing on government to commit more funding for the INGOs, it's also to bring in more local actors, because local actors have been shown through research that whenever there is a violent incident or any crisis situation, they move along with the communities they belong to, and so continue delivery of health services. Additionally, intersectoral, interagency collaboration, and also with traditional institutions. And then mainstreaming psychosocial support. There was a lot of GBV cases, especially among the upper class working women around COVID times, especially during the short period of lockdown. Many women were stuck with their abusers. There's the frustration from the economy that saw husband lay hand on wife, wife lay hand on children. And then the whole trauma that's caused by the recurring violence in South Sudan also just really needs for health practitioners to mainstream psychosocial support into all its activities. Okay, that's it. That's the end, and I'm open for comments and questions when the time comes. Thank you very much.
Thank you so much, Ayak. I'm just going to put Sandra's presentation up now.
Hi, Noon. Apologies for the background noise, and I really hope that it stops soon. All right, so thank you so much, Ayak, for your presentation. I personally related to a lot of the information you shared, because I also did risk communication and community engagement during the COVID-19 fight in South Sudan. So a lot of these rumors and misperceptions are really part of our daily COVID-19 encounters, whether it's community members or response teams trying to curb the disease. So it's really been a challenge. And I believe behavior change communication is really a journey. So as much as we do try to fix it within a timeline, like 6 months or 12 months, it's really a journey. And I think we may need other outbreaks. Not that I'm hoping that to have other outbreaks, but we might need to see perhaps a few more encounters until we actually do accept the fact that emerging and re-emerging diseases are actually real, and that we as community members can actually take part in it. So hi everyone, it's good to see you all in the hall. My name is Sandra Banks, and I am proudly born and raised in Khartoum, Sudan, and I graduated from the University of Juba School of Medicine. Initially, I started doing surgery, but then coming back to South Sudan in 2011, I gained interest in public health and in particular infectious disease outbreaks. And I just recently concluded my master's in public health from the Johns Hopkins Bloomberg School of Public Health. And now I'm part of the School of Medicine and Department, University of Juba, and also part of the Emergency Preparedness Country Office, focusing mainly on planning and monitoring on COVID-19 and displaced populations, which I believe for us, particularly in South Sudan, this has been part of our everyday stories, growing up as children, being told that your parents, your uncles, your cousins have ran away and fled, but also something that you've also been seeing in Sudan as well. But our focus will mostly be on South Sudan. All right, so when it comes to South Sudan, the country's been going through more than 5 decades of civil war, perhaps 7 years of war, if I can go back in time. And it's been 11 years since we gained our independence. However, as much as we hope that we would see peace and stability prevail, that has not been the story. And there's ongoing continued violence until just 2 days ago when we had casualties in Kajukeji County, which is not very far away from the capital city. And we've also had lives lost, mostly, of course, due to intercommunal violence, intertribal, cattle raids, and there's usually abduction of women and children, which have had significant humanitarian impact in several counties, and revenge attacks. And of course, not to undermine the armed conflict and armed violence between government, state and non-state actors as well. South Sudan also is undergoing lots of, we like to refer to it as climatic change because it's been very frequent in the last three to 4 years. However, we've had floods and droughts, locust infestations, etc., all of which has been affecting food security and livelihoods. And of course, our never-ending drama of disease outbreaks. So we've had several rounds of cholera. The country is currently undergoing a measles outbreak. We've had meningitis, influenza, hepatitis E virus outbreak, which has been ongoing since 2019 in one of the IDP camps. We've had anthrax among the animal population. And of course, our dear best friend, malaria, which continues to be the largest contributor to morbidity and mortality in South Sudan. And as of recent COVID-19, even though our numbers do not really highlight to that. And South Sudan, in as much as we are responsible maybe for the top 5 or top 10 countries who are exporting, let me say, refugees, we're also a recipient of refugees, migrant workers, asylum seekers, etc. So some of the leading causes of morbidity and mortality in the country, as I just highlighted, we have malaria, acute respiratory infections, tuberculosis, etc. We also have diarrheas, road traffic injuries, and trauma due to several causes, including gunshots, of course. And like I just mentioned, other infectious diseases. And as of recent, we've had non-communicable disease also contributing greatly to some of our high morbidity and mortality cases, perhaps due to improved surveillance, but of course, several reasons as well. And not to undermine that, Sudan has the high, among the highest maternal mortality rates and under 5 mortality rates in the country. And this image of the skeleton of a fish is just to show that hunger might actually be one of our biggest problems, let alone health and health-related conditions. So a lot of these problems actually come from the resources that are availed and committed to health and health system strengthening. Of course, during the Civil War and pre and post Civil War, the health system is fragmented and continues to struggle due to the ongoing conflicts and natural disasters. There's also a high staff attrition. So the Ministry of Health initially, or since independence, we've had just, I know on the graph it says 2%, but the real truth is that the Ministry of Health has been allocated less than 1% of the national budget. And we've had a promise just last year that that budget is going to be increased to 10% of the national budget. And we really hope that this actually materializes and happens, because it is one way through which we can strengthen the health system and health service delivery across the country. And of course, a huge proportion of the health services in the country are contributed to by non-governmental international NGOs and national NGOs as well. So just a repetition, a lot of these issues are actually due to the ongoing conflict. We have a fragmented health system. We have a very weak surveillance system. So it would take days and weeks until diseases are detected and responded to. And of course, we have our competing priorities. A significant portion of the resources are allocated to bring stability and peace and security, etc. So that has been the priority over the last decade or so, rather than social and public services. And of course, we have our natural disasters, the droughts and the floods. And of course, all of these contribute to what we've been, what we call a protracted humanitarian crisis in South Sudan. So this is just a humanitarian snapshot from March 2020, which is just the month right before our first cases of COVID-19 were actually reported in South Sudan. So our population averages is just around 12 million people. So when we look at 7.5 million in need, we actually have almost 60–70% of the population in need, which is quite a significant number. And I think I'm just going to fast forward to December 2022, which is our recent humanitarian snapshot. And we can actually see that the numbers are actually increasing. So we have almost 9 million people in need, or 75% or 80% of the population. We have more people being displaced. We have more people being food insecure. We have higher number of malnourished children. And also, if we look at the map, the two maps at the bottom, we can actually see that with regards to food insecurity, we previously we've had several counties in crisis level of the IPC, but now a lot of them are actually going into emergency, and we've had at least 3 to 5 counties that what we've actually declared a catastrophic or famine stage of food insecurity. So there's a lot going on, and we have almost 4.5 million people displaced. More than half, or just around half of those people are internally displaced persons. So again, it's not the conflict, but also floods. Floods contribute significantly to population displacement. And the map just shows all the areas where we have ongoing floods. And these blue circles on the map to the left just kind of gives us an impression of the number of people that are affected by these floods, whether they're directly or indirectly affected. And of course, floods, we have 2 rainy seasons, one that will probably starts around April and another around August. Over the last 3 to 4 years, we've had very heavy rains. And I believe, I clearly recall that a state of emergency was declared twice in 3 states, at least in 2019 and 2020, because of massive flooding that has led to millions of people being displaced. So when we have floods, in the wet season, we have floods affecting populations. And in the dry season, we have lots of conflict because we have people moving around with their cattle, looking for grazing lands. And then this leads to intercommunal conflicts and violence. And it's just a vicious cycle of instability. So I'm sorry, I know that I have a lot of maps, but this again just gives us another snapshot of where we have our internally displaced populations. So the map here just shows us a significant portion in central Equatorial State, but we also have in the northern central part of the country, Warab State, Lakes, Jonglei State, and in particular, and Upper Nile. So almost half or more than half of the states in the country are IDPs from different counties in different parts of the country. And again, this just shows us the location of refugee camps. So we have, like Ayak said earlier, we have across the northern border of the country and across, just right across our border with DRC and slightly Uganda. This is where we have a lot of population movement. And the map on the right just shows us we have around 5 IDP camps. Some of the protection of civilian sites have been transitioned to IDP camps over the last 2 to 3 years. And we also have a significant portion of people living within these IDP camps. And these are populations that have limited access to health services, food security and livelihoods, etc. So this is a snapshot just from yesterday, I believe, from our health service functionality dashboard. And it just shows us, this has been specifically done by WHO, the Ministry of Health, and the International Organization for Migration. So they mapped out all the locations where we have internally displaced persons and refugees, and these are the purple dots that you see. And yellow dots indicate functional health facilities, and indicate non-functional health facilities. And I think we can see that where we have lots of yellows, we have less purple dots, which means we do have a significant portion of IDPs and returnees actually not having access. And this particularly reflects the number of IDPs or locations where IDPs and returnees are more than 5 kilometers away from health facilities. So in South Sudan, we have just around 1,980 health facilities. Our dashboard says that 83% are currently functional, but during the time we had COVID, we had only about 53 or just under 60% of these health facilities functional. And I think if we just focus on the last column here, and if we look particularly national level, we have 30% of IDPs are placed more than 5 kilometers from a health facility. But when we look at the states which house the largest portions of IDPs, Jonglei State, Warab State in particular, which is the last one here, almost half of or 50% of IDPs live or reside more than 5 kilometers from a health facility. So that's just roughly maybe a day or two of walking distance. And depending on the terrain, depending on the season, depending on the weather, and depending on the security status, it could actually take you longer to reach a health facility. And sometimes you would get to a health facility and it's not functional, or it will be open, and we'll have staff there, but there are no tools and essential medications to take care of individuals. So this just gives us a brief reflection of what displaced populations are going through in terms of access to healthcare. This is just another figure. Again, looking at Central Equatoria, Warab State in purple, Jonglei State in yellow, the yellow circles, and Upper Nile, and Unity in the blue circle. It just shows us a significant portion of these displaced people actually are living far away from healthcare facilities. So COVID came in 2020. Our first case was reported on the 5th of April. And like Ayak previously shared, as of yesterday, we've had just around 18,500 cases, which is very, very small, despite us having almost 85 testing sites across the country. But our testing remains low, and up to date, we haven't even exceeded 500,000 tests. And these include PCR tests and rapid diagnostic tests as well. So clearly we're not testing enough. And I know that is a number that perhaps China could do in a week. But for the last 2 or 2.5 years, we haven't even tested 500,000, or we haven't conducted 500,000 tests. And our case fatality rate remains very low, 0.75%, which again is very low. And we currently have 176 active cases. And none of these cases are actually admitted to the infectious disease unit, or maybe we can say to high dependency unit or critical care, or even admitted to hospitals. So all these 176 cases in the follow-up are just undergoing home treatment. And almost 80% of them really have no symptoms, which again kind of gives us how COVID has impacted South Sudan differently from many parts of the world. Again, just some maps to show, just comparing between March 2020 and April, when we've had our first cases reported. So the maps on top shows us where we've had incidents of conflict and humanitarian aid workers being attacked, incidents of looting, other bureaucratic impediments which have been hindering humanitarian access, of course, for several reasons, whether it's taxation or just access to communities. And a month or two later, we had COVID come, and along with COVID restrictions, and we can see that all the counties in blue, whichever shade of blue it is, these are counties that have incidents of conflict and displaced populations. And almost all these counties have had COVID restrictions. So this further impacted the delivery of aid, not just humanitarian aid, but COVID-19 aid in particular. So several measures were put in place before our first case was announced and after the first case was announced. These included border closures, whether they were international or state, road travel, air travel, were all suspended. We also had visa restrictions, and I'm just looking at it from the eye of humanitarian response. So we had key humanitarian staff and personnel who were not able to access the country and to access their duty stations due to these restrictions. So there was massive delay in humanitarian response. We've been seeing the conflict didn't stop because of COVID, violence didn't stop because of COVID, the floods didn't stop because of COVID, but humanitarian actors could not reach communities and communities themselves couldn't reach public service facilities to receive aids. I also remember I was part of the COVID incident management team, and we had to take personnel through a 14-day quarantine prior to travel from Juba to the state level. So that also impacted the response greatly. And they needed to get COVID-19 pre-certification and mandatory COVID-19 testing at a time when we needed to test people who were symptomatic. We needed to test high risk individuals, but the priority was shifted to testing people who were disease-free, contact cases, because they needed to travel to the state or to travel to a location, we needed to get them tested, and we had limited tests. So even in displaced people were not being tested, and almost 90% of the testing being done in the first 3 to 4 months after we've announced the COVID-19 outbreak was for reasons really reasons other than surveillance and reporting of cases. And there was also delays with release of goods from revenue authorities and movement of goods from Juba to the state level. And lots of clearance and taxation, bureaucratic impediments, like I mentioned. Even if you wanted to import PPE and masks, etc., you had to go through a series of paperwork with the high-level task force, and it would take 2 to 3 weeks to get any single item into the country. We also had disrupted essential health service delivery, which I believe was one of the greatest downfalls of COVID, just taking us, I'm not going to say it took us by surprise, but when your health system is not ready to counteract and respond to, it really did heavily impact us. So people receiving TB dosages and people living with HIV and all these other diabetics and people with high blood pressure who needed to get access to medications. It was very, very difficult, and particularly malnutrition cases. These beneficiaries couldn't access nutrition facilities to get care. So again, just part of our response, we had set up the Dr. John Garrett Infectious Disease Unit, supported by IMC, the WHO, and other partners. But this was a 24-bed capacity. So we're looking at 2.3 million displaced persons and 300, almost 500,000 refugees and asylum seekers in the country. And we only had 24 beds and 12 ventilators. So there was, it was clearly very challenging for us to try to think, okay, who deserves to be put on a ventilator if it needs to be. We had very few ambulances posted in IDP sites to aid critical patient transfer. But I remember at least 2 or 3 patients were transferred from the Juba POC to the IDU for care. And of course, violence didn't stop. Just in the 3 months after we reported COVID cases, 8 workers at subnational level, we had to move them around, 4 were killed. And again, a lot of it was due to COVID-19 and COVID-19 restrictions, and goes back to echo what Ayak was saying with regards to misperceptions. So a lot of these communities were hungry and they needed healthcare, but here you are coming with a mask and asking them to mask and wash their hands, and really and truly all they needed was food. So there was a lot of rejection from communities as to what type of care they deserved. They didn't want to hear about COVID, they needed food to feed their hunger. And of course, insecurity blocked assistance, rains and flooding as well, and the bureaucratic impediments that I previously mentioned. So just reiterating again, when you have people living in such conditions, they really want to get out of the water to safe lands, moving away from waterborne diseases and snake bites, because that was contributed. We had significant deaths reported from snake bites from water, or really and truly you want to give them a mask to put on their face and to stay away from each other in times where all they needed to do was to really hold on to one another and to build their relations and to stay close together. And here we come with all our COVID restrictions, asking them to stay away. So it was really challenging. So I'm just going to share results of a study that was recently published just in June 2022. And it was done in collaboration with WHO, the Ministry of Health and other colleagues, and they looked, they tried to do an epidemiologic characterization of COVID-19 in displaced populations, and they focused on the Bantu IDP camp, which hosts just over 100,000 displaced persons. So it was a very brief descriptive cross-sectional study. And I know there's a lot of writing here, but I just want us to look at the table and to focus what's in the red box. So basically what they tried to do was to calculate the attack rate and the case fatality ratio and to compare between the rates in the Bantu IDP camp and what was being documented at the national level. So the cumulative attack rate within the IDP camp was 3 times that at the national level, and the case fatality ratio was 20 times or 20%, almost 20% higher than that which was reflected at the national level, which again, I know it was only 1 camp out of 6 or more across the country, but it just reflects, given the dire living conditions, the water and sanitation conditions there. Of course, there's not adequate ventilation. You cannot keep people away from each other. So within a very short period, within 5 months or so of the study, we've had 66 deaths. And we're talking about 2.5 years of COVID nationally. So these 66 deaths, so just the deaths within the Bantu IDP camp account for almost half of the deaths that have been reported in South Sudan so far. So this just gives an insight on how critical the situation was for IDPs within the camp. And I think for Bantu IDP camp, they've also had cholera outbreaks, and they continue to have an ongoing hepatitis E outbreak within the camp as well. So looking at the COVID-19 response, of course, I believe like what happened in other countries, we had our country coordination and planning, our surveillance, the points of entry, doing IPC wash and risk communication, community engagement, etc. And we've had a lot of non-governmental organizations, such as the IOM and the UNHCR, and several partners from the health cluster in the responding to the human or contributing to the humanitarian response plan, who are part of all of these pillars. I know that IOM, the International Organization for Migration, were the co-lead partner for IPC and co-lead for case management as well. And they also contributed greatly to laboratory, where they started rolling out antigen testing at points of entry. So we had all these partners looking after displaced populations who really played key roles in the COVID-19 response. And of course, we had our vaccine technical work group, which is something we'll talk about in the next few slides. So it's good to say that displaced populations were not excluded from plans when we're putting together the operational or country preparedness and country response plan for COVID-19. And that picture there was is just a picture of me inside the Juba POC, which I believe also just recently transitioned to an IDP camp, which is one of the biggest camps in South Sudan. And I was at that time with the Red Cross, and we were just, that was before we had COVID-19 cases announced, so none of us were wearing masks, but we were just conducting a training session for community volunteers on risk communication and community engagement for COVID-19. So a lot of partners were also there doing similar and providing other activities as well. So I think when we talk about COVID-19, we do need to talk about COVID-19 vaccination, which is key. Ayak also earlier mentioned that we just have just over 2 million doses, which has been given out so far in the country. And of course, when it came to prioritizing or the inclusion of displaced populations, South Sudan in their vaccination development plan, they used the SAGE roadmap, and which ensured that people with vulnerabilities, risks, and needs were actually included, specifically those who bear the higher risk of disease and death, just as we saw in the Bantu IDP camp. Again, displaced populations, people living with disabilities, extreme poverty, the homeless, refugees and asylum seekers, nomadic populations, populations in conflict settings and other humanitarian emergencies, and those who are hard to reach. So it's good to say that all these population categories have been considered when putting together the South Sudan Vaccine Development Plan. And again, they use the principles of human well-being, equal respect, ensuring equity globally and nationally, reciprocity and legitimacy. And I'm just going to share this picture of one of the first refugees who received, I believe this was during the second month, after which we rolled out our first vaccination attempt in the country. And this is an Ethiopian refugee. I know he looks completely South Sudanese, but yeah, this is an Ethiopian refugee who received his first dose of COVID shield at the police hospital here in Juba. I took this snapshot on the 2nd of February, 2 days ago. The country has just launched its nationwide COVID vaccination campaign in order to catch up with the missed doses and missed opportunities because we've had a lot of logistical impediments and delays with rolling out our COVID vaccination in the country. And on the 2nd of February, just 2 days ago, we had 28 counties, I believe, that have rolled out the vaccine. And just this morning, I took this other snapshot, and now we have 58 out of a total of 80 counties. They have rolled out or started their COVID vaccination. And I'm happy to see that several counties hosting IDP populations are also highlighted. And I believe that these IDPs will also be reached. However, I know that I indicated on the map to the right, the circles or the dots in red just show some of the counties where we still haven't started or launched the national campaign and where we still have a significant number of IDPs in the country. Again, on the 2nd of February, just looking at our current vaccination coverage, countrywide, 16.8% of the population has been vaccinated and just under 40% of the target population. And when we look at what is in the red box here, percentage of eligible refugees fully vaccinated, just around 19.8%. And the percent of eligible IDPs fully vaccinated, 3.5%. It's actually good to see that in our COVID dashboard, refugees and IDPs are actually included alongside the elderly, healthcare workers, and those with disabilities, and that they're actually recognized as a high risk and vulnerable group. This morning, after seeing that 58 counties are now carrying out COVID-19 vaccination, I took another snapshot, but unfortunately, the percentage for eligible refugees and IDPs have slightly gone up a bit, which is I'm not extremely happy. But we hope that over the next coming weeks, couple weeks or more, that we start seeing significant increases in these percentages, and that we start seeing that these at-risk and really needy populations get vaccinated because COVID cases are still reported from these locations. So I think just to conclude, I just want to share some stories. This is a story of Mary from Age International, which is an NGO that supports the aged here in South Sudan. And Mary lives in Mahad IDP camp, which is located just less than a kilometer from where I'm actually sitting. I think maybe 500 meters from where I'm currently speaking. And so Mary joined the camp about 5 or 6 years ago, coming from Jonglei State. And when COVID came, it affected her. She lives alone in the camp. She doesn't live with her family. And some of the things she said that social distancing was very difficult because houses are next to each other and the camp is crowded. And people avoided each other when fetching water, given the fact that there's only one water pump within the camp. And without assistance, medicine was hard to find. And for all people, going to the hospital carried a fear of catching coronavirus there. So, and Mary also recalls that hearing that let's not greet, let's not stay close together. And when you look at an aged person who lives alone in an IDP camp, her family is not there, her children are not there, her grandchildren are not there. She does need that element of psychosocial support, which COVID also took away. In addition to the fact that these people, like I earlier mentioned, their main concern is food and health, not really putting on a mask and washing hands. We also have Teresa. Teresa is based in the Mangaten camp, which is also in Juba. And some of the things Teresa recalls is that when coronavirus came, the things we did normally, we had to stop. We couldn't meet other people, water wasn't there, and we had no food. And in the community, people were afraid of coronavirus, but because they couldn't do anything, they would sit idly at a distance. And she also said that during coronavirus, I would go out of the camp looking for food and some vegetables on the ground to bring back so that we could eat. So I know that earlier I mentioned that a lot of standard operating procedures were tailored for COVID-19, but until these SOPs were put together and validated and shared with the relevant clusters like the nutrition cluster and the food security and livelihoods cluster and education cluster, health cluster, etc. It was weeks and maybe 2 to 3 months or more until these adapted SOPs could actually be rolled out in these camps and where humanitarian actors could actually come to the camps and deliver assistance that was interrupted by the movement restrictions that COVID-19 brought along. And also a very near and dear group to my heart, which is the street children that we have. And I also consider them displaced persons because they're not living in their homes, and a significant portion of them do not live in their counties or towns of birth or origin. And of course, due to conflict, and again, so far we haven't had any studies that were done to look at the impact of COVID-19 on these three children. And again, I wonder how things were for them. And it's an area that we really need to look at. So yeah, I think maybe the way forward, of course, peace and stability. We need policy to consider and include IDPs, including street children, because we really don't have a clear policy or guideline to cater for their health, education, shelter needs, etc. And we need the equitable sharing of resources and resource allocation with the health sector. And hopefully this will contribute to, increase and stabilize the economy. And maybe we can come up with a health plan where we can ensure that there's equitable access for healthcare to all the not just the 8.9 million people living in need today, but the whole population of South Sudan at large. So thank you very much. Over to you.
Thank you so much, Sandra and Ayak. We'll open the floor for questions now. We've got one from the audience. I'll just get the mic.
Thank you so much, Sandra. Can you hear me? Thank you for the presentation. Very informative and interesting. And it was really great to see how displaced populations were included in the response and the community engagement. And I was just thinking this highlights how can certain vulnerable groups face compound crisis from multiple sources at the same time. This further increases their vulnerability. And I was wondering whether there was a certain framework or strategy that was followed by humanitarian actors to respond to the needs of those vulnerable groups that would be facing compound crisis, for example, COVID, conflict, and natural disasters at the same time. Thank you.
Yeah, I got the question. And apologies to my sister. I don't think I got her name, but thank you so much for asking the question. So during the time of COVID, like I mentioned, one of our biggest concern in the country is, of course, the humanitarian context and how it keeps unfolding. We really can't say expectedly, but also unexpectedly. We would sign a peace agreement today, and we have a pocket of violence around the country. We would put measures in place to mitigate floods or mitigate drought, but then something else would happen. So most of these humanitarian actors, they do have their principles that they work with as the mandate of their organizations. For example, the UNHCR, they have the principles and mandates. WHO has the core principles as well. And I believe several of these humanitarian actors also roll out and plan and roll out their activities in line with what we generally call the humanitarian principles and as guided by sphere guidelines, etc. So all these have been considered, and I clearly recall because when COVID started, I was with the South Sudan Red Cross, and then I joined the World Health Organization country office, and so working with all these different humanitarian actors. All of these organizations would bring their proposals and put it on the table and say, you know what, this is how we operate, and we are not going to put together a plan that does not go in line with our mandate. So all the guidelines and SOPs that have been drafted, even nutrition and maybe not so much education, but nutrition and IPC wash, and risk communication and psychosocial support, all of them were drafted holistically, and of course being led by the government. Um, and they took into consideration all these different contexts, whether it's humanitarian, whether it is sensitivity, community related or tribe related. So all these things were considered, which is why they also took quite a long time to be validated and finalized. So yeah, so all these things were considered and put in place, and several fora and sessions were actually held to ensure that no one was left out, and that no measure was actually left for these populations to be met. Thank you.
Thank you.
Khalid Zaki. Shukran Sandra for this presentation. Just it looks like international non-governmental organization perspective. Where is the government role on those all that? Because I see only the IOM, OSHA, and I think there is some from UNDP. It looks like there, and I don't know where's the government role in this kind of intervention and how you coordinate this one, because this report is mostly from WHO website. So how can we see our local government in this kind of responsibility, because there's their communities, there's their people, and they work for them. How you can engage them in this kind of initiatives?
Thank you so much for your question. The government actually played a key role in terms of coordination. And of course, for example, when I mentioned WHO is just more or less a technical partner and provide support to maybe other organizations. But the COVID-19 response was government-led. And as Ayak previously mentioned, we had what we call the National Steering Committee, which was the National Ministry of Health, and we had several technical working groups or pillars of response, and each pillar was led by a Ministry of Health focal person. And when it comes to the NGOs and INGOs, they were the co-leads of these pillars, and they were co-leads in terms of they're either providing technical support or they're providing logistical operational support. And of course, I think when it comes to donors, donors are donors, and donors actually support countries and support INGOs as well. But all these SOPs and all these guidelines were produced hand in hand with the Ministry of Health, and the Ministry of Health was actually the lead. I won't say the lead partner, but the owner and the custodian of all the response pillars. And of course, I know that I did mention that there were a few hiccups in terms of bureaucratic impediments, and I think that's also because we had a technical national steering committee, but then we had a government, a high-level fora, which was established just just weeks before the COVID-19 outbreak was announced, and everything had to go through them because, of course, we thought, I mean, everyone thought that COVID-19 would impact South Sudan with a very high magnitude because of the way our health system is, the health system capacity, the resources, and all these disasters that are ongoing. Even I remember Johns Hopkins predicted that we'll have about 2 million cases, but none of these eventually happened. But we did have to go through the response and the planning and the coordination was government led, but of course, as the case is in many low and middle income countries, we have INGOs contributing a significant portion technically and logistically in the support as well. I think there was a point I wanted to mention, but I forgot. But for example, when we look at logistics and PPE, a lot of it was donations. The government did procure a significant amount of PPE, and the government also they did try to contribute to ownership and spearhead these activities, specifically at the state level, which is where we needed them the most. So the leadership was there, the governance structure was in place, but because we do have limited capacities, limited human resources, limited capacities in terms of tools, utilities, facilities. INGOs did need to step in and give the support that was expected of them during such times. Thank you.
Thank you.
My name is George Omondi from Kenya. Great work to Dr. Ayak and Sandra on the COVID-19 work with the communities in South Sudan. So my question is to you, Dr. Sandra, slightly related to your presentation. I work on snake bites, and you mentioned significant snake bites reported during the COVID-19 period and related to the flooding. Is this data that you're looking to get out? Because in Africa, we suffer from lack of data from snake bite, and this really affects policy decision around this disease. Thank you.
Yeah, thank you so much for your question. Recently, I was putting together a conflict public health situation analysis, but I was looking at a template that was a flood situation analysis. So that document had a lot of reflection on snake bites. And I also was doing an exercise which made me go through the DHIS2 or the District Health Information Surveillance System tool, and I was looking in particular at road traffic accident injuries and how they're documented, and I noticed that snake bites are actually one of the things that we do have to report in South Sudan, and it's part of the it's one of the injuries that are listed in our IDSR and our DHIS2 data collection tools, and these are things that we actually do need to report against. But I am not sure that we have any studies that have been conducted to reflect on that. I think maybe because the numbers are minimal, and because, you know, in many situations we have the snake bites, but really and truly countermeasures or anti-venom and all these other medications to treat and manage are not readily available and not readily considered part of a humanitarian emergency health kit, for example. But I'll be happy if you wanna discuss this further. I'll be happy. We can, you know, talk and see how we can look at extracting data and information related to snake bites, specifically those related to flooding in South Sudan. Thank you, Sam. Thank you.
Richard?
Thank you, Noon. Actually, it's a question from myself, two questions. Firstly, you made some observations about the role of international organizations or INGOs. I think you were referring to sort of the withdrawal of staff and perhaps slowing of their operations in the early phase of COVID. But both your presentation and yours, Sandra, also make clear the very significant role that the organizations from WHO through to IMC and others that they played. Do you have any reflections, Ayak or Sandra, do you have any reflections on the roles of international organizations and thinking about the idea that they have one goal that they have generally, or policy goal, is localization, to localize their operations and staffing? So that's the first question. And then the second question to either of you, just if you have, do you have any comments about estimates for the excess mortality rate in South Sudan and Sudan during the COVID period? I've seen that one set of statistics that tracks that internationally, managed by The Economist, indicates that for South Sudan, the central excess death estimate is around 16,000, whereas for Sudan, it's around 130,000, quite a lot more. I don't know anything about the reliability of those estimates in that survey done by The Economist, which is otherwise quite well regarded for data and estimates for wealthier countries. Yeah, so second question, do you have any reflections on the question of excess mortality rates in Sudan and South Sudan during the COVID period? Thank you.
Thank you for your questions. Since I think South Sudan has unfortunately been in a state of perpetual humanitarian need, we're always in a situation of responding. And so most interventions are responsive interventions. Obviously, there is a dependency on INGOs. That is a reality. It is also coupled with the fact that the government is overburdened with the pursuit of peace. It is seeming a bit elusive. The health system itself is overwhelmed. We are in a state as well of perpetual transition. And so even as a country, we're still going through institutional reforms in all its forms for all service institutions. And this keeps on getting interrupted by these circles of protracted conflict. My take, and these are personal reflections, is that just as we are urging government to commit more, to take up more ownership of the local health situation and really stop this over-dependency on the foreign aid organizations. Foreign aid organizations too have a role to play. This is, there needs to be some change in some of these countries' foreign development policies, especially on funds that are targeted towards humanitarian aid. There is usually a vacuum, and this is a reality. And this is not just, within South Sudan, even within refugee camps. When COVID-19 hit, all the aid partners withdrew. And so it was just a terrible, terrible situation, given all the other compounding factors. Yes, there has to be local ownership. INGOs have to have exit strategies, You cannot tell me that WHO, UNHCR, UNICEF have been in South Sudan forever. And up to this point, they have not been able to capacitate locals to take up key positions where, with or without them, some of these services and some of these interventions would not be interrupted. And so this narrative of lack of capacity really needs to be washed down. This narrative of lack of South Sudanese cadres, yes, I understand there is a monetary aspect to it. Most of funds going to INGOs go into this cycle of training for capacity development. There is capacity. There is just the need to get the right local actors into these positions so that when crisis does occur, there is no gap. It does not mean there is no need for international actors, but there has to be local ownership. There has to be an exit strategy, because we want local ownership. We want South Sudan to be in a situation where we are able to take charge of our health system and get the necessary assistance when and if needed. So those are my personal reflections.
Thank you, Ayak. Terrific answers.
I think we've got one question from the floor. Yeah.
Hi, my name's Victoria Iman. My question is to both of these ladies. First of all, thank you for your presentations. My question is in regard to the vaccine itself. How have you felt or seen the South Sudanese people deal with the vaccine, accept the vaccine, and how are we still promoting it now in this supposedly pre-pandemic era, are the South Sudanese people willing to accept it? And if so, are we still using the same means of promotion that was said before by Ayak when we were informing others of COVID and its pathway and so forth? Thank you.
Sandra, do you want to jump in with answering the first question first?
So yeah, thank you so much, Ayak, for your response. And I just, I really wanted to echo the same and to add that perhaps in the beginning of the COVID pandemic, we did have maybe lesser capacities at the state level, but I know that I personally was part of a series of trainings and certifications and courses from 2014, 15, 16. And I was part of I was also a national rapid response team member. So as we had the Ebola outbreak in neighboring Congo in 2014, we did a series of trainings and capacity building, as we call it, not just nationally or centrally here in Juba, but also at the state level. And I think when COVID came, because lots of these health cadres already had IPC, infection prevention and control training in place, we had a very good base to set up from and to just maybe adapt it to COVID-19, which is a respiratory illness. So lots of trainings and capacity buildings and job aids and support for health cadres across the country has been happening, and of course guided by the Ministry of Health. And like Ayak said, we do have capacity. The capacity is there, but we just need to support that capacity. We need to ensure that, for example, my own experience, my own opinion is that the Ministry of Health needs to put together a mechanism where we can retain these healthcare workers and avoid attrition at state level and national level. I know that we have at least 20, 30 rapid response teams of 10 to 20 persons each have been trained and established at state level, different counties and PIAMs. But we need to maintain that. We need to ensure that these rapid response team members who have not just been trained on Ebola, preparedness and COVID-19, but also other notifiable diseases, infectious diseases, and other health threats as well, that we continue to give them the support, and that the ministry continues to provide that support. And of course, this is just from the preventive side. From the clinical side, I've witnessed several of my colleagues over the past 5 to 7 years go overseas to neighboring countries to specialize, obstetrics, gynecology, surgery, orthopedics, you name it, radiology. And they're all 80–90% of them, if not 100%, have come back to South Sudan, and they're providing services not just in Juba, but also in the different states. So the capacity is there, but we need to ensure that that capacity is supported. So we have the human resource now. We need to ensure that the facility is functional so that we are able to deliver optimal healthcare at the grassroots level, not just in Juba here. This is something that hopefully would come along with the promised 10% allocation for health that was promised last year. And we really hope to see that 10% being delivered to the Ministry of Health, and to see how to see it being used to improve health service delivery across the 80 counties in South Sudan. And also with localization of efforts. I know that a lot of donors, let alone INGOs, a lot of donors are now adopting this thing that if you want to conduct a health response or a health project or program, it needs to be local. So it's not just the staffing is local, even whatever materials, if you can source them local. So you need to include that component and to ensure that whatever funding you get, there's going to be a significant localization component in executing or implementing that project. So these are things that are coming along, maybe less so before, but now we're seeing more and more and lots of that happening. Even organizations as WHO, for example, and IOM and others, if they want to do a community health project in a state or county somewhere, they do not send people from Juba, but they do look for existing national non-governmental organizations and existing capacities from the ministries of health and county health departments to actually contribute to that. So that's excellent. And we really hope to see that continuing to grow. And of course, a lot of us who leave the country for studies, we are back. So we've come back and we continue to give the support that we can to the country. And we hope that more of us come back and to continue giving support as well. So maybe I'll jump to the next question with regards to the vaccination. There's been a lot of demand generation activities that have been ongoing, but the challenge remains, of course, the misperceptions of vaccination. Commonly between people is that this misperception of impotence and losing your ability to produce, which has been very high frequency within communities. So it's good to see that we have key figures, key leaders who are actually participating in these vaccination campaigns. And just recently, last week, when the national campaign was launched, we had His Excellency, the fifth Vice President, receive his second or third booster, I believe. And I believe that through leaders contributing to sharing knowledge and to setting examples, we will be able to get communities to accept the vaccines more and more. So over to Ayak. Thank you.
Thank you. Ayak, any final comments before we close this panel and this panel?
Yeah, I guess just the hesitancy, of course, with the vaccine uptake. There is a lot of hesitancy, the myths. Vaccine has been the biggest challenge. As much as we're able to communicate the rest of the information, vaccine uptake is the biggest challenge. Dr. Iman, your question was, have the strategies changed? Yes, the strategies have changed because the priorities have changed. The messaging has gone lower. It is not as aggressive, the messaging on COVID vaccines. However, the messaging now is the fact that even if you've been exposed, you still need, even if you've had COVID before, the vaccine still helps you. So the messaging has been tweaked a little bit to suit the context, to suit the declining number of cases, but also to remind the communities to be mindful that, you know, like other viruses, there is a chance that this virus might surge again, and it's always good to be prepared. My final comment is thank you very much for availing us the opportunity to share the South Sudan experience on this platform, and for all the questions shared, all the comments. We're very grateful. Thank you.
Thank you so much. I'm just going through the chat box. A lot of thank yous to both the speakers and in support of agreement of what you've spoken about. I don't think there are any more questions in the chat box. So we'll take a quick break before we have our final two speakers who are here in person, who will have the chance to present.
Well, thank you very much. Thank you from those online. Thank you.